This is a small case presentation on mucus fishing syndrome. My hope here is to present this case, discuss some specific clinical pearls so that we can all learn from my mistakes, and then bring in some information and parallels from a completely different field of medicine to spark some interest in the intersection of optometry and psychiatry. This is a little bit about me. My name is Isabel, and I'm currently a cornea contact lens and ocular disease resident at Mass Eye and Ear in Boston. Let's jump into this case. A 53-year-old woman was referred to the cornea clinic from the emergency department. She was extremely distressed about her right eye, which she stated had a multitude of foreign bodies coming out of it, including white coils, for about 3 months. The photo here is of the inside of a face mask where she had been storing the debris that she was picking out of her eyes. She told me that this was just from one day and that she had a ton of tissues and face masks full of debris. In the photo, we can see some clumps of what I thought to be hardened mucus and a number of black hair-like fibers. Her past ocular history included dry eye syndrome for 4 years. I put DES in quotation marks because via chart review on our EHR system, I could see that previous eye doctors had diagnosed and discussed mucus fishing syndrome with the patient, despite having dry eye syndrome or K-SICA as the formal diagnosis. She was currently on a steroid drop, an antibiotic ointment, and oral doxycycline from the emergency department, and was given instruction to not touch her eye and instead use sterile ophthalmic saline to flush out the eye, which she reported she was doing 6 times a day. I've listed the various treatments that she had tried in the past, none of which had helped her. Her past medical history notably includes anxiety and depression, as well as neurodermatitis, which is a skin condition where a minor rash or bite causes the patient to itch and creates a snowball effect where they continue to itch, thus exacerbating the issue. I am not a dermatologist, but she also had multiple scabs on her forearms, which I associated with the neurodermatitis. Here are a few photos from the patient's visits to the emergency department and cornea clinics. To clarify, I saw this patient on the date with the box in red. In terms of the conjunctiva, we can see interval improvement from first presentation to the second and third visits. However, in the third picture, we can see that an epi defect is now present. The patient was aware of this defect, which she described as a white spot. This concerned her even more because she felt that it was additional foreign material in her eye, rather than the disrupted tissue that we as optometrists know it to be. Due to this epi defect, we stopped the steroid drop to promote corneal healing and increase the antibiotic ointment dosing frequency. 2-day follow-up, not pictured here, showed small interval improvement. 1-week follow-up, pictured here, showed continued interval improvement, and the plan was to follow up again in 3 days. The patient unfortunately did not return and sought care at an outside office. Additionally, of course, each time the patient was told not to touch her eye, that it was a vicious cycle, and the more she touched it, the worse it got. But clearly this treatment strategy did not work. While we were seeing slow interval improvement in the immediate issues like the new epithelial defect, the patient was still correctly noting that the entire problem as a whole was not getting any better. Telling this patient to stop simply was not working. Here are some of my thoughts on what we could have done differently with this patient. Throughout her numerous visits with us, we really only used one communication strategy. I think we could have elicited information from her in a different way, as well as educated her in a different manner when we realized that the patient was only getting more and more distressed. To make a comparison to a different aspect of eye care, I think optometrists are pretty good at asking low vision patients in a non-judgmental way about driving and tailoring the discussion about driving to their individual patient. Had we applied those communication skills here, we might have been a little more successful. Another similar issue in the communication realm is that our specific EHR system shares the visit notes with the patient. The patient saw the term mucus fishing syndrome in her file when she opened it up at home and told our clinic staff that she completely disagreed with that diagnosis. This is something to be mindful of when working with mucus fishing syndrome because the name of the condition can rub some patients the wrong way. Another thought I had about this case was that some of her systemic medical history seemed fairly similar to her ocular history. This led me to look into the possibility of being more mindful about integrating her systemic medical history into the diagnosis of mucus fishing syndrome. I would say that the seminal paper on mucus fishing syndrome is from 1985, which describes the disease as a mechanical, self-induced trauma to the ocular surface resulting in increased inflammation. Notably here is the aspect of being a mechanical, self-induced trauma. Let's look to similar conditions throughout the body that involve self-induced manipulation or trauma. One such example is body-focused repetitive behavior, or BFRB. Most formally in the literature, BFRBs are skin picking disorder and trichotillomania, otherwise known as hair pulling disorder. But within the field, we see that nail biting and lip or cheek biting are also included as BFRBs. According to the Standard Classification Manual for Psychiatric Illnesses, the DSM-5, BFRBs are part of obsessive compulsive and related disorders, or OCRDs. Based on my literature review, research attention to BFRBs has increased mainly in the past 20 or 30 years as it has become part of the OCRD classification. And much of the research acknowledges the relative recency of the disease and that there is still much work to be done in understanding etiology and treatment of BFRBs. One study from 2016 investigated the comorbidity of skin picking disorder and trichotillomania and found that having two BFRBs significantly increased the severity of the disorders, and that having multiple BFRBs increased the likelihood of also having depression. Looking back to our case here, we could see that our patient with mucus fishing syndrome also had diagnoses of anxiety, depression, and neurodermatitis. This case is a perfect example of why I believe that mucus fishing syndrome should be included in BFRB and OCRD research. Knowledge about BFRB comorbidities and the ability to predict severity of an MFS case could allow the optometrist to tailor their treatment approach to a patient more precisely. I hope this brief case has brought to mind the potential complications of mucus fishing syndrome, both physiologically and psychologically. As the relatively new field of psychodermatology matures, I believe that optometrists can and should play a role in marrying their knowledge and experience of this ocular surface disease with the larger classification of body-focused repetitive behaviors. Here are my references, and thank you very much.